Hello, everybody. My name is Dr. Maria-Ahmed Qureshi. I'm currently having a research fellowship with the University of Catania in Italy. I'm extremely delighted, and it is a very big honor for me to be sharing our research work with you all here. And of course, it really helps further my commitment to tobacco harm reduction. So today I will be presenting on respiratory and cardiovascular health effects of e-cigarette substitution for cigarettes, a living systematic review. So we believe that research should be completely transparent, available, and accessible to everybody. So for this reason, I would like to invite you all to please go ahead and have a look at our published protocol in the Journal of Medical Internet Research Protocols, which is also available at the given DOI. So our research question is that what are the respiratory and cardiovascular health effects resulting from the substitution of electronic nicotine delivery systems for conventional cigarettes? So for all of us who are working in tobacco harm reduction, this is a very crucial, a pivotal, or rather a central question. It is a question which we are all looking for the best answer. But to find the most accurate and best answer, it remains a challenge. So many other researches have been done, systematic reviews have been done, which are trying to answer the very same question. But the problem that actually happens is that by the time most of these systematic reviews, they become available, they are published, they become outdated. The other thing is that many of these reviews are frequently based on non-human studies. Now, this leads to inconsistent results. In comparison to all of these other systematic reviews, what is unique about our review? So our review is a living systematic review, which means that we will be keeping it updated regularly. And we will be ensuring that all new relevant and important research is brought out in a good, timely manner. So this was our PICO. Our population is adults who smoke cigarettes. The intervention was substitution of ends for cigarettes. Our comparator are participants who continue to smoke or within subject changes for participants who substituted ends for smoking. The outcomes that we measured for respiratory function were changes in respiratory tests, and in cardiovascular function were changes in cardiovascular tests. So the PRISMA 2020, it has been recently updated to the PRISMA 2020 from the PRISMA 2009. The new PRISMA, it is much more comprehensive, advanced, and more modified. And this is the PRISMA that we utilize, and we believe that it has really helped add quality to our research work. Now, during our research process, we extracted 33 studies with 38 publications. We used two excellent tools, the JBI tool for assessing the quality of our studies. Now, this is a very good tool because it really helps in assessing whether how reliable and how relevant and trustworthy a study is. And we also used the Oxford Catalogue of Bias. Now, this catalog has more than 50 biases in them. We extracted 22 relevant biases, and then we measured the biases which were present in each study individually. We think that these two tools are really good, and all researchers should definitely be using them. It would really help improve the outcomes of their research. So by using these two tools, what we came across was it was really not very good news. We saw that 26 studies were rated at a high risk of bias, and we rated 7 studies with some concerns. We found no studies that could be rated at a low risk of bias. So the research that we actually came across, it was highly flawed, it was highly biased, or to put it more bluntly, we found junk research. We were not able to find any conclusive answers on health outcomes. So let's move on to the tests that we looked at for measuring or for looking at the health effects of ENDS. For the respiratory studies, we basically looked at spirometry. And for cardiovascular studies, we looked at blood pressure, heart rate, flow-mediated dilatation, and electrocardiogram. We also conducted a subgroup analysis to see the changes in the test for dual users, for those who were using these products or ENDS for more than a year. And we also looked at populations which were having an underlying disease. And what did we find? We found very mixed results, especially on the specific populations. Now, this brings us to our results. This is definitely the most important section of our work, basically because it helps validate the fact that we really did not find any good research. So what did we actually see? We saw that there were some benefits to patients with hypertension, but with a low certainty of evidence. We saw some improvements in people with COPD who switched to ENDS use presented only in the long-term studies. Acute and short-term follow-up studies were unable to establish any health effects. A decline in further worsening of asthma in those who switched to ENDS compared to those who continued to smoke was also seen. So again, I cannot stress enough, we think that what we found was highly flawed or basically junk research. To put it out there to all of you, I would like to ask you all, what does this actually say about our field? Where are we headed to? Are we progressing or are we going backwards in all the research which is related to tobacco harm reduction? Where are we headed? I would really like to know that. So what were the issues that actually led to all these flaws and biases in the science? We found that many studies had methodological errors and reporting biases. If we talk about methodological errors, we saw that many studies did not have adequate power. We saw that studies were reporting significant p-values, but not clinically relevant outcomes, which actually makes the results or the significance meaningless. We saw that many studies were using different ENDS models. Now, this makes it very difficult to standardize results across different studies. The puffing protocol was something very interesting as well, which we came across. We saw that studies were actually having excessive exposure to the puffs, and we saw this in 3 studies. We also saw that studies were utilizing very high nicotine levels. Now, with all of this, we can say that these are not real lifelike situations, which means that we cannot get real lifelike impacts or results as to how these devices are actually affecting the people. Another thing that we noticed were reporting biases. We saw studies with missing and discrepant data. We saw issues due to deviations from protocol leading to data dredging. We saw that studies had a lot of spin bias, which is very important for conclusions. This was noted more in studies that failed to show any significant findings. Now, in end science, demonstrating that these devices have no significant difference in health effects compared to smoking is highly relevant. If the evidence is distorted, it would be depriving potential users and the clinicians of the actual findings. It means that their decisions would not be true, not true reflection of what actually is happening. So please, researchers, if you have a study which has no significant findings, report it as it is, as that in itself is a very important and significant finding. Now, two very good study examples that I would like to quote here, which have these errors and biases, are one study was by Flores, which reported statistically significant p-values, but when we went deeper in the study, we saw that those p-values were meaningless because there were no clinically relevant outcomes. Also, we saw that the study failed to report the results properly. They only had bar charts, and we could not see any proper values to show what the significance actually meant. Another study we saw was by Barna et al., in which we saw that ENDS users were reverted to smoking cigarettes. Now, this put the participants at a high risk for relapse to smoking. We really fail to understand how in the world this study went past ethics, and this study did have an ethical clearance. So researchers, we all really need to adhere to the ethics of research. We simply cannot harm risk to the participants. Now, this was very important that we compared our systematic reviews to other systematic reviews. So we compared, the comparison was with systematic reviews which were not older than 2 years. We really wanted to highlight what our review is adding that is different and not already present. So in our systematic review, we only included human studies. We excluded cross-sectional studies as they can only show an association and not a causation. Animal studies as they do not reflect human exposure levels, which means they cannot give the evidence for presence or absence of risk. We excluded in vitro studies as they do not look at all the systems together. And we also excluded biomarker studies. Now, biomarker studies only show surrogate outcomes, which do not have a predictive value for tobacco-related diseases. So they do have a limited or a prominent role rather in screening, but that's where it ends. They have a very limited role in indicating the presence or absence of a disease. So we would like to urge all the researchers who are working in our field that we should really forget about biomarkers as they're really not useful to our research area. Another interesting thing that we noticed was that none of the other reviews had actually conducted a quality appraisal of the included studies. That is why I was stressing that we really need to start. We have excellent tools out there and we really need to start using them. None of the studies, rather than just one study, had actually conducted a bias assessment of its included study. None of the other ones had. So we can say that we found that the conclusions of these reviews were very problematic. Recommendations for future research. We have a lot of recommendations by which we can actually improve the research that we are going to be producing in the future. So the randomized control trials, they should be adequately powered with an adequate control group and a longer term follow-up. Excessive compensation, it actually introduces bias, especially for vulnerable participants, and this should be avoided at all costs. If you look at specific to ends, blinding and masking is very important. And whenever there is use of ad-lib choice of flavors, it adds further confounding. So this also should be excluded or rather avoided. Protocols should conform to the Pennsylvania University standards. Future longitudinal studies, they should actually stratify the results according to smoking behavior and history. And most importantly, populations who are heavy smokers or have failed at multiple quit attempts should be included as important research participants. So what is our conclusion? So we conclude that the respiratory data showed no harmful effects with ENDS use in healthy participants and improvements in the long-term outcomes of patients with COPD and asthma. The cardiovascular studies showed no or only a slight increase in heart rate blood pressure with the use of ENDS, which in every case was smaller when compared to smoking. We conclude that END substitution is not harmful to health and may have some limited benefits, particularly for those with respiratory disease or hypertension. In the end, I would like to request all the researchers, we need to keep an open eye for biased research. So we should all move forward so we can find the best possible answer to understand if END substitution is a worthwhile treatment option for people who smoke. Thank you very much.